Hola. Well, good afternoon. We're about to start another CAP Sprint seminar. We have the pleasure and honor to have with us Professor Eduardo Simões, who is a distinguished professor at the University of Missouri, director of the Health Informatics and Diabetes Research Core of the Center for Diabetes Translational Research. And he will be talking about metabolic syndrome, epidemiology, risk factors, treatment, and prevention. And he should be answering questions at the end, if you may. Dr. Eduardo, please take the floor.
Thank you, Luis. I have to look because you're a little bit too tall for me. I'm kidding here. I'm going to speak from the podium. I'm not going to be moving around because this is a webinar and you out there is a more important person, although there are four people here in the audience. But without further ado, let's start it. Thank you for the introduction, Luis. The topic today is metabolic syndrome. The target population for this is anybody who may be interested in metabolic syndrome, but more specifically, this is aiming to primary care doctors, to preventive medicine doctors, nurses, and healthcare auxiliary people who deal with patients who may become diabetic and they already have metabolic syndrome. You may not know. So that's part of the gist of making this presentation. So we're going to discuss what is metabolic syndrome, the epidemiology of it in the US. Unfortunately, it's not Brazil. I didn't have time to prepare for Brazil. I'll love to. And next time, I promise I'll bring data from Brazil. Causes of metabolic syndrome. In the cause, we're going to discuss a little bit about environmental, social, behavioral causes of metabolic syndrome because it's more population-based, that little section. Then we're going to say, wow, metabolic syndrome, does it increase risk of what? Yes, as you know it, diabetes, type 2 diabetes, but more importantly, heart blood vessel disease. They're the precursor. You may develop heart blood vessels like a stroke and something related, even without having the path through diabetes. So the metabolic syndrome is a risk factor for that too. And we're going to touch a little bit on dementia. It will be a completely different lecture because this is very new research clearly indicating that dementia is kind of a second type of diabetes. It's almost the next step of metabolic syndrome. Clinical manifestation, diagnosis of metabolic syndrome. This is for the docs and the nurse. Management treatments for docs and nurse, and a little bit on prevention. So what is metabolic syndrome? It's a cluster of conditions that occur together that increase your risk of develop type 2 diabetes. It's almost becoming impossible not to develop type 2 diabetes because you're going to see later on that metabolic syndrome and insulin resistance, they are linked. Actually, insulin resistance is a way to say you have metabolic syndrome. We're going to talk about that a little bit. So the conditions I'm talking about is blood pressure, which is high blood sugar level, excess body fat around the waist, and we're going to look into something interesting about adiposity in your body and how that influences metabolically and cell-wise, immunologically, your body. And then abnormal cholesterol and triglyceride levels. Not surprisingly, metabolic syndrome is related to cardiovascular as well as diabetes. So we think right now the consensus is that metabolic syndrome is caused by adipose tissue dysfunction, meaning fat in your body. And insulin resistance may be the next path or maybe in a separate independent path of causing it. Dysfunctional adipose tissue, which is a kind of a modification, not just having adipose, but you have dysfunctional adipose tissue where it is located. And we're going to see a little bit, may play an important role here. Both adipose cell enlargement and infiltration of macrophage into adipose tissue result in release of pro-inflammatory cytokines and promote insulin resistance. So this is an area that I would love to do a whole lecture on it. We have an immunologist here, Dr. Valkyria, and she'll be very important person I would invite to present with me. But this is an important and new developed area in diabetes and chronic disease in general. A little bit just bird's eye view of the metabolic syndrome. As you know, we're talking about hypertension, we're talking about insulin resistance, we're talking about abdominal obesity, and we talked about the dyslipidemia, cholesterol, low HDL, high triglycerides. So what could be causing it? I'll be a little bit more of that later. Don't waste too much time, but the critical path here is adipose tissue. It's really clearly related to what we call FFA, free fatty acids. I put the acronym on the right-hand side so you can follow in the PowerPoint presentation. So you're going to see some positive feedback and some negative feedback on the FFAs, but also the cytokine has a direct effect on vasoconstriction as well as a negative effect on the pancreas, make the pancreas become less active and produce more insulin resistance indirectly. So FFA combination with fasting blood glucose and the cytokines, it's causing all these things. So you can see that increase of blood pressure over there, 130/85. You're going to see that later on the definition and the cutoff for blood pressure, for glucose, and for the other issues. Insulin resistance, you have fasting plasma glucose going up. If you have sporadic increase in your glucose level, by chance you measure in the middle of the day is high, it doesn't mean that. But if you stay 8 to 12 hours, no eating, fasting, and then your blood glucose is 120, yeah, you have diabetes, or at least metabolic syndrome. We're going to see that. So what is metabolic syndrome? There are 4 definitions. I'm using 2 here, and later on I'm going to show a third one. The one I go by more is the one on the right. International Diabetes Federation is being more widely adopted than the one developed by World Health Organization. So if your waist to hip ratio, or just the waist, okay, when you measure around the umbilicus area, it's over 94 centimeter for male, 80 centimeter for women, and you have 2 or more of the following. So there are 4 other factors here. You can have 2 of those plus the abdominal growth. So blood glucose greater than 100 milligram per deciliter. HDL that is less than 40 milligram per deciliter for men, and 50 milligram deciliter for women. And then blood triglycerides that's greater than 150 milligram per deciliter, and the blood pressure is greater than 130 to 85, which is kind of a borderline hypertension, and that you consider treating. You need to be really sure that person has hypertension to start treatment with that. That's kind of borderline, but it's considered by many centers and by American Heart Association kind of a hypertensive, because your systolic is 130. Okay, in my time when I was practicing medicine here in Brazil, I trained in cardiology for 2 years in residence. It was 140 by 90. Okay, which still very much in use by a lot of centers. So now you know what metabolic syndrome is abdominal obesity with 2 or more of the following: blood glucose level that's high, HDL that's low, triglyceride that's high, and blood pressure that's high. So if you're a nurse and you see patients with that and the symptoms of something else, but you see a patient, because I don't know how we're doing here these days. I haven't practiced medicine in Brazil in 35 years. I'm only in America. But over there, a patient comes in a primary care clinic, atenção primária here, right? Primary care clinic. First thing they do is to weight you. Take your body weight. Take your height. The clinic I had at Emory way back about 20 years ago, Emory University in Atlanta, we also took the abdominal obesity. You're going to show why. Because I was involved in 2 research that, for the first time, connected abdominal obesity with standard coronary death. And it's published American Journal of Cardiology. But they would take the body weight and they would take the blood pressure, right? And then if the clinic is all connected, the nurse, how educated, a registered nurse to go after your cholesterol level, so they can classify already a person's metabolic syndrome. Not all services do that, many do. Okay, but you can do that. It's very simple, right? This is the constellation of symptoms and signs, in this case, clinical signs, that a person has a metabolic syndrome. So with that definition, metabolic syndrome on the right, this definition here of IDF, slight variation. I don't want to get into that. You can read the paper. I put the papers here at the bottom. You can then see the growth of metabolic syndrome in the United States between 1988 and 2012. So you can see here no Hispanic white man on the left-hand side, Mexican-American men, meaning Hispanic men, but more specifically Mexican-American. That means they are descent from Mexico. Just a little bit wording on this. Hispanic in the United States is considered all Latin America except Brazilians or people from Haiti or people from the Guyana. But all the Spanish-speaking people are considered Hispanic. We are not. But the Mexican Americans is a special case, because when these studies were done, there are like 90% of all Hispanics in America. Now it's not so much true anymore, because the middle section of the America, Central America, has really migrated a huge number, and Mexican have gone down substantially. They actually gone back. Millions of Mexicans went back to Mexico. So it's a little changed. This is from 2012, still very much truthful. And that's why I brought these numbers to you. So you can see no Hispanic white man. That means the traditional, typical American who is not Hispanic. The prevalence of metabolic syndrome classified, as I described it to you, has gone up substantially from about 27% to over 35%, just like the over 35%. Okay. Likewise, the prevalence have gone up for Hispanic men or Mexican American men. It's gone down a little bit and up altogether. Maybe that was a fluke. The survey, it may be, but it's such a long time in between. And in Haynes is a good surveillance system. Very, very seldom you can say this large-scale survey of America is done wrong. That survey collect also blood from all the patients and measure all the clinic values of the blood. Okay, that's why, and they also take blood pressure of patients. They take metric, take height and weight, not just self-reported. So take height, weight, blood pressure, all kinds of blood levels of sugar, triglyceride, cholesterol. That's an Haynes survey. Okay, so it has gone up for non-Hispanic white men over the past 20 years, and then has gone up also for the so-called other groups. You can see non-Hispanic black men have gone up too, as well as Mexican American. The standard error is this little bar here. You can see that between Mexican American and non-Hispanic black men, they're very similar. The confidence interval kind of across each other. Therefore, there's no difference between them. But non-Hispanic white men has really gone up, and they're way higher in their prevalence of metabolic syndrome. It's very similar to what's happened to women on the right-hand side. Very similar, except that on the right-hand side, non-Hispanic black women have gone up substantially. They're about the same level as non-Hispanic white woman. So this is a summary that I made it to you of that graph, but I'll focus on something else. It's important to note the incidence of type 2 diabetes was higher among certain ethnic groups. Okay, so even though this is about, prevalence of metabolic syndrome, I have pulled information from another paper that shows that the prevalence of type 2 diabetes was higher among certain ethnic groups. Okay, over time it has gone up, like 15% among American Indian, but lower among Chinese American. South Asian Americans had very high prevalence of metabolic syndrome too. So the other subgroups, I focus here on white, blacks, and Hispanic, more importantly, Mexican American. But there are some other subgroups you need to pay attention, like the people from the subcontinent, India and Pakistan, had an incredibly high also prevalence of metabolic syndrome and diabetes, type 2 diabetes. Prevalence of metabolic syndrome. So you saw those numbers. However, this is a little breakdown. Say, okay, among the non-obese participant overall, can I have prevalence of metabolic syndrome non-obese? I mean, I'm not obese, but am I having a metabolic syndrome? Yes. You may not have enough obesity to be classified as obese. You may be overweight, but you have an abdominal obesity, which is a localized fat in your mentum. Okay, well, we get a little bit of that. So in there, you can see that the prevalence for the non-obese participants, the prevalence of metabolic syndrome remains stable. Okay. The prevalence among the obese is a little different for Hispanic white men and Hispanic black women and non-Hispanic women. Okay, they have increased from 15.3% to 25%, 14.5 to 20.9. So this is like, okay, I'm non-obese, and overall, my prevalence has not gone up too much. It's about the same. You see that, the different times period. However, if I'm non-obese and a non-Hispanic white woman or black man, it has gone up. Okay. So that's reflective in another way of looking at the metabolic syndrome, which is the prevalence of the factors that compose the metabolic syndrome. And you can see here that these factors have not gone up too much, or have gone up a little bit and down, like central obesity. It was already very high at 60% of the population in the US between 88 and 2012. And then 2017, 2018 had what we call central obesity, which is obesity around the belly for men, okay, and for women. That is the worst fat you can have. I'm going to show it to you later why. Then you have high triglyceride that has gone down actually over time. But still the metabolic syndrome is going up. How is that possible? Because of high glucose. So there's something else besides just, the obesity, which has gone up a little bit. It's already very high. Maybe it's just time. It takes time for people to accumulate and do that. Maybe there's some other factors. Just want to call the attention. It's a little different than this graph by the different groups, okay? Because here I show each of the components of metabolic syndrome. And you can see glucose went up, undoubtedly. Central obesity went up a little bit, stay a little bit higher, but not much higher than before. You stayed at 59.7 versus 57.7. It's only at 2% out of 57. Okay, it's less than about 5% increase. Okay. So this is a summarization. I'm going to skip that in the interest of time because I want you to ask me a question, and there are a lot of other stuff. This is just the epidemiology. Okay. So let's talk about what are the causes of metabolic syndrome. These are the things I put over here. There's a lot of new stuff that because the science is not solid yet, I didn't put out there. I put only the stuff that's solid. So age, undoubtedly one of the biggest risk factor for metabolic syndrome. Okay, your risk of metabolic syndrome increases with age. That's based on population epidemiological studies. But can you separate the effect of age and the effect of overweightness or obesity? Is that the age, or as we grow older, your lifestyle change, your body becomes a little bit less effective or efficient, so to speak, in generating energy and burning energy, and then you accumulate weight as the weight that's causing. It's not separated here, it's just together, right? Ethnicity, Hispanic, especially Hispanic women, appear to be at the greatest risk of developing metabolic syndrome. The reason for these are not entirely clear, okay? But I suggest, based on previous study I've done at CDC nearly 30 years ago, that there's something people confuse a lot. Oh, is that genetic? Oh, it's genetic. Genetic is it's a strong thing. You may have some genetic predisposition and not really be genetic, but you may have something else that people forget. It's called familiar, meaning your culture, your dietary culture is familiar. I mean, it comes through families. Many people say, oh, everybody in my family is heavy. I've done that study way back. And sometimes it's nothing to do with genetic. Most often it has to do with the culture of eating that's passed on from generation to generation.
Is there anything with menopause on women?
Yeah. The menopause.
I guess.
The Dr. Valkyria asked about menopause in women, if that is a factor. I didn't put over here because after some age, this thing gets even worse. And it's really around menopause time. Once you hit 50, between 50 and 60, you certainly are going through menopause. And why I didn't do that? Because the same happened to men. So men do have menopause too. Not well understood like women, but both are related. I'm in menopause. I'm 68. So technically, you know, but I did keep my body weight the same since I was 17. No, I did? No, I'm exactly the same way. Yeah. But anyhow, obesity, that's the big one. Carrying too much weight. You know, the association, the relationship between type 2 diabetes, metabolic syndrome, and obesity. Our simple question, the metabolic syndrome is not really obesity, it's about abdominal obesity. But do you think it's more or less likely that a person has obesity overall to have abdominal obesity? It's more likely. I mean, you're already obese, you may gain more weight here than there. You see what I mean? So the two come together. However, you have lots of people, I have not measured, I may find the next lecture, I may find the prevalence for that, of people who are not overweight or obese, but do have abdominal obesity.
Yeah, well, there are some reports as well about internal organs, fat tissue.
That's what I'm saying, abdominal obesity.
But internal organs.
Yeah.
And
Oh,
you not have a belly,
yeah.
internal organs of your
Okay.
fats, the fats.
Dr. Valkyria from Unifast is saying that there are some studies showing that the organs have fat associated with, like the viscers, but they don't have abdominal obesity. I never seen a Valkyria. I'm going to have to look into that. Okay, but usually fat liver. Okay, it's associated with abdominal obesity. The abdominal obesity, it's very interesting. I would say my experience clinically, I don't have an epi on that epidemiology, is that 50% of the patients who have abdominal obesity are overweight or obese. But the other 50%, it's just slightly overweight, but they have a huge belly. So those who are slightly overweight have the huge belly. Their fat is only in the omentum. It's inside the omentum. The omentum covers all the viscers, right? That's your peritoneal area around the viscers. And then you have the sub layer of the great rectal of abdomen muscle. And then you have subcutaneous layer for fat and so on. I have one brother, my identical twin brother, whose belly is hard. He has no fat like subcutaneous. And I have another one that has a huge belly, but is 100% subcutaneous. So they do have different mechanisms for gaining their body weight. We're going to see a little bit of that. So that's part of the genesis of metabolic syndrome and diabetes. You're more likely to have if you have diabetes during pregnancy. That's another interesting thing. Pregnancy, gestational diabetes predispose you to have metabolic syndrome and later on develop full-blown type 2 diabetes. And as you know, polycystic ovary syndrome is associated with gestational diabetes. It doesn't matter if you operate and remove your polycystic ovary, you're still at risk. We don't understand the mechanism, but the polycystic ovary syndrome, which affect the whole hormones in your body, will predispose you to a gestational diabetes and to metabolic syndrome. So these are some of the risk factors. So if you're there, primary care doctor, your nurse, pay attention to this lecture. Find your people with metabolic syndrome. Attack this issue aggressively to prevent them from becoming that full diabetic. What are the causes? Again, I'm still on the cause. The underlying etiology remains unclear. Yeah, absolutely. I gave you a lot of ideas already. But known risk factor for metabolic syndrome includes, like I said, family history, poor diet, inadequate. They are all associated with this aging and overweightness and abdominal obesity and metabolic syndrome. Okay? And I think I always bring the story of me and my twin brother, because we married two sisters and we had the same digital. We are identical twins. Until about 25, you could not tell us. I see my picture with him until age 25, and I don't know if it's me or him. Can you see how identical? Now, he has 110 kilograms. I have 67. He has hypertension for the past 5 years. He has diabetes now. He was metabolic syndrome. He has fat liver, and he sleeps with a CPAP. Yesterday, I ran 6 miles on Birapuera. And every day, I run 3, 4, 5 miles. Because I like it. Never stop it. He was a great athlete, and he changed. So he developed this. This is a perfect study, right? Twins. And the only difference between us is the body weight. But the body weight is also associated with a lot of factors. He is a night guy. Okay? He loves eating a lot, drinking a lot, and he leaves every night. He has to go out. Okay? So he said one day to me, I'm eating this pururuca, right? With the thing. What's the worst, the pururuca or the alcohol? I said both. Yes. But then he said, well, but if I eat this, I'm not going to have dinner. I said, well, that's better. But I will have dessert. I said, that's worse. See how bad this guy is? It's like everything that's bad.
But there are some students from same areas showing that once they get apart, like moving from country or getting married or something,
We see.
they can move, they can change so much. They're not brothers or siblings anymore. They have so many different.
Exactly.
Including on the immune
Well,
system.
in the discussion time, I'll allow it. More discussions fine during, but I hope that more people out there would ask questions. Is anybody manning the chat to know if there are questions there? Can we ask them to look at the questions? So 2/4, let's continue. So I don't have too much. 2/4 that have spread metabolic syndrome globally is the increased consumption of high-calorie, low-fiber fast food. So it took over the world about 40 years ago, and it used to be only a phenomenon in the United States. Now it's a worldwide phenomenon, okay? I went to China in 2003 working, and everybody was eating McDonald's and Burger King already in 2003, everybody. And people are supersizing the fries. So they're not, there's no chat? Okay. Well, folks out there, figure out how to send me I think my email is associated. Send an email. I will respond to your questions later on. I'm sorry for that. So lack of physical activity, we're going to see a little bit of that in very high calorie dense food. So other contributing factors, I call contributing because the epidemiology is there. Sometimes it's strong, sometimes it's very weak. But I could list, I mean, we already know insulin resistance, even in the absence of abdominal obesity, so it would predispose you to metabolic syndrome, then later on, type 2 diabetes. Pancreatic beta cell dysfunction, it's diagnosed already, but it's a very rare thing because sometimes we don't know what came first. Is that the beta cell dysfunction or what we cause it, the pancreas, to become dysfunctional? So that's why the preceding issue is not there. So we don't know in time-wise what comes first. However, cellular dysfunction by protein kinase and phosphatase, that's a fact. And the fat precedes them. The abdominal obesity, actually, it's linked to all these things. I mean, it actually stems from the abdominal obesity. Obesity and lipid toxicity, oxidative stress, and glucose toxicity. So I list a bunch of things I found in different papers, but they're not strong enough in repeated epidemiological study to say this is a factor. Where these were for sure, okay? Disrupted circadian rhythm cycle. We're beginning to learn more and more that lack of sleep is at the heart of all of that. People are very stressed. They don't sleep well. If they sleep at least 6 hours, they will not sleep deep. And that affects your insulin resistance levels. That's already shown to be associated. Genetic and epigenetics, there's more to it. gut microbial balance. They found relationship with gut microbial balance and dietary effects in general. So the occurrence of metabolic syndrome was dreadfully high among diabetic population, especially among female subjects. Metabolic syndrome caused diabetes, but also sometimes the person developed diabetes without having metabolic syndrome. Many, more than 50%. But once they have it, they will start to develop the metabolic syndrome. So it's almost like one is not necessarily a stage where the other will come. Meaning metabolic syndrome may precede type 2 diabetes, but you also may have the reverse. You have type 2 diabetes preceding metabolic syndrome. Okay? And maybe a diabetes and metabolic syndrome association, the one that's going to cause your heart to have problems. Almost to say, I may have a diabetic person who doesn't have high triglycerides and low HDL. But it's just a matter of time, in my opinion. But I need to see the studies to do that. Central obesity, again, is linked to all of that, but it's significantly high in females more than male, the central obesity. The most frequent. Remember, men, when they gain weight, usually is around the belly. Women, when they gain weight, because the hormone is around the hips. So if the woman starts gaining way more fat in the body around the abdominal area and not around the hip, we have shown gradients that their risk of developing a sudden coronary death is higher than the men who have an abdominal obesity. It's almost like you expect men to have abdominal obesity, but not women. Okay, so it's kind of what they call, I want to show later on, a androgenic look for the woman if they gain weight there. So need to be on the lookout if your fat accumulates on the abdomen is high risk. The most frequently occurring risk factor in the study was central obesity, like I said, followed by hypertension. So it's almost like my brother hypertension could be well explained by the fat. I'm going to show a diagram very soon on that. A comparative analysis of the two definitions of IDF, one that I already showed to you that I'm using here, and the NCP, which I'm going to show later. Second slide I had was WHO and IDF, but I have another one I'm going to show later. But a comparative analysis, these two implies that when compared to diabetic patient without metabolic syndrome, all the metabolic risk elements are significantly higher in diabetic patient with metabolic syndrome. You see, if you understand what I wrote here, I already said that before. I said, when compared to diabetes patients without metabolic syndrome, that means I have diabetes, but I do not have metabolic syndrome. I just have insulin resistance, and my glucose level is above what's considered to be normal. So I'm technically a type 2 diabetes, okay? But I cannot be classified as metabolic syndrome because I don't have, for instance, the abdominal obesity. Or I may lack the low HDL. I may have a high HDL. My brother has high HDL. It looks like it's familiar because mine is kaboom, is 96, and his is about 90, and he had been obese for 20 years. So all these combinations, but basically saying all the metabolic risks were significantly higher in diabetic patients with metabolic syndrome. So metabolic syndrome by itself is a very high risk for a complex diabetic patient. They will have more cardiovascular proneness. They'll be more likely to develop. So that's what I was talking about, folks, about this abdominal obesity. Most men, when they gain weight, is around here. Actually, I wish I gained weight in my butt because it's getting smaller. It's always in the abdomen if I gain weight. That's typical of men. That's your hormone pushing it. Okay? Where women, the hormone push it to the hip area. Okay? And it gains to the abdomen a little bit. So you have to gain here to get there. But many women have this other pattern, like men. And that's much more dangerous for women than for men in terms of risk of cardiovascular event. According to criteria proposed by the Japanese Society of Internal Medicine, the prevalence of metabolic syndrome, why I'm putting this down, because we're changing topics already here. I'm just saying that lifestyle is very important. Look at this number here. Prevalence of metabolic syndrome is 13.9 and 2.7%. Huge difference, right? for native Japanese men and women, and 32.7 and 3.4% for Japanese American men and women. So the first two prevalence are for Japanese men and women. Men is more likely to have metabolic syndrome than women, but Japanese men born in Japan. But those who migrated, they are second, third, fourth generation Japanese, and they are in the US, the prevalence more than double for men and increased by about 65 to 70% for women, just because they are no longer in Japan. And we have studies and studies like this. This is migrant studies. We've done that in cancer, colorectal cancer. We've done that in cervical. We've done a lot of stuff. And it's about lifestyle. It's lifestyle change. And okay, you mentioned that when men migrate from their original place to another, even twins become very different after 20 years. Okay? I definitely did not keep my body weight and my stuff because I went to America. Because America is the reverse. Should make me exactly like my brother is. It's because he changed his lifestyle completely. Was a great athlete, stopped exercise, stopped playing in sports and eating like an animal, drinking like an animal. Hey, it's gonna get to you. According to IDF and AHA, the prevalence was 2. I'm not gonna. You can read this. Westernization of lifestyle is associated with metabolic syndrome. That's the way it is. If you do immigration migration study we've done, I put a reference here for you in Oneda, and you can see that person does for Japanese, but also review the literature, and you can see that happen to all people. People in Italy, the most immigrant from Italy, they come from Sicily to New York. Okay, Sicilians are very healthy, but not the Italian descent in New York City or New Jersey, where they're predominant. You see what I'm talking about? So this is all over. So westernization is meaning to say adopting an industrialized, high-calorie, high-density, but very low nutrient density, high-calorie, high dense of calories, but not nutrients diet, and becoming extremely sedentary. It's going to cause you to have metabolic syndrome and diabetes and cardiovascular health. They're all linked. They're all the same disease, my opinion, based on epidemiology. It's a little bit more about the entire behavior. A diet low in fat is what was promulgated back in 1962 by a man called Keyes. He created the Keyes equation. Okay, I'm not going to get into that, but that man was extremely biased and very powerful, very connected at the federal level in the US. So he was able to convince a lot of people with no real trial, no even good cohort study, just by association, that dietary fat was a bad thing. And the whole world bought into this. I went to medical school here in Brazil, graduated from Recife School of Medicine, UPE, they call it UPE now, University of Pernambuco. It used to be Fundação de Ensino Superior de Pernambuco, Medicine, School of Medicine. It was like excellent, so good school. And that back in that time, I was already indoctrinated that we should not eat fat. I never believed it. I did my own study and I made a presentation at Morehouse College in 1994, basically saying this is BS, if you get my drift. Okay? This is BF. Where's the evidence? I see the evidence to the contrary. Secondary evidence, because people did not focus on it, but I got the data on. So that was a dangerous thing we did for 40, 50 years. And then we end up fabricating a new diet for Americans based on carbohydrates. They used to have a better diet until late 50s. Very balanced, like most people did. So they adopted this crazy diet, which is really refined carbohydrate. Not going to get into that, but add refined carbohydrate in cereals, pasta, rice, everything is industrialized was injected with corn fructoses. Why? Corn fructose allows you to play with the taste of the food, the smell, the flavor. It keeps the food in the shelf for 6 months to a year to 3 years to 4 years without spoiling. And it gives you size, you increase the size. But It adds a lot of calories. So pasta in Italy, made of real semolina, has about 1/3 of the calorie of the pasta in the US. They're changing now. There's Barilla pasta there that does the same. But that's what they had being fed for 40, 50 years. No surprising they have the highest rate of obesity. But we adopted the same thing. What do you think happened to the tortillas in Latin America? They adopted the corn fructose because that's industrialized. The companies who own that, they're the same companies in America. Okay? And also start eating badly. Out of that came Cheetos and stuff like that, right? Anyhow, not going to get into that. You can read it. Then associated with reduced physical activity. Many ways, I want to show that. So the food environment, in addition to this fast food, to the industrialized, high calorie dense, very low nutrient dense type of diet and reduced physical activity, came also the added bonus of fast food establishment. It's not the main cause, but one of them to contribute less healthy food and beverage advertising at children. Okay, here, let me get straight. Here, I'm not so worried about the burger itself. I'm worried about this bread. If you put this bread in your mouth and wait, don't do anything, don't chew it, just put it in your mouth and wait for about 30 seconds, you dissolve. Now take a hearty bread made like traditional hearty French bread in Brazil from my time when I was a kid. You have to chew it, otherwise it wouldn't dissolve. You need to put a lot of saliva and mastication to make it, to break down and stop breaking the amylase, stop breaking down the sugar, right, the saccharose in the blood, in the bread. In addition to that, you have French fries. Supersize me, right? You got a bunch of French fries, like 1,000 calories, a large one. It's 1,000 calories, the supersizing. 1,000 calories. I can live in 1,000 calories every day, but I only have one nutrient, carbohydrate, and a little bit of fat. So increased frequency of meals eaten away from home, that's another thing we studied. We start eating out. I've been here for about 10 days, and Dr. Ramos eats out every day, twice a day. Not too healthy, Dr. Ramos, but that's what everybody does here. I realized because I went to the restaurant, all the faculty and the students and the staff, they're all here in the restaurant. Finesse, right? And all the others around. So increased frequency of meals eaten away from home. I was lucky to love to cook, and my wife loves to cook. We always eat at home. Always. I've not made a point. If I'm to work, I'll take off, go home and eat, and then come back to work and do the same at night. Very rarely. Truly, I eat very little there. Dietary behavior. This is an interesting graph. I wrote a paper. I should have listed my paper. I put Woodward paper. Hey, bam, that's bad. This is sugary drinks. Okay, sugar beverages. Okay, so account for at least one fifth of the weight gain between 1977 and 2007 in America. The average amount of drinks, like sugar beverage drink, the American drink, it's just unbelievable. It has gone down substantially. You can see that line on the top. You see that line on the top? By 2007, start going down. That's regular soft drink. You see the one on the top? But we stopped measuring only about 1983, the soft drinks. We stopped measuring it as a public health issue. So it went up, continuing up. It was probably the secular trend, likely it was lower and start going up in the 60s and 70s and reach a peak around 1998. And US start coming down. But look at the others. Everything start going up. Look at this one here, which is soft drinks. Okay. Look at fruit drinks. It's going up. So that's a big contribution of calories. Anybody knows how much calories is a Coke? Do you have any idea? Okay, homework, folks. Check how much calories in a Coke. It's equivalent how many teaspoons of sugar. a tradition, about 8. Okay? Think about water, put 8 teaspoons of sugar, shake it and drink it. That's what you're drinking. How much calories there? Oh, it's close to 200 calories. Okay? So, not a good thing. Physical inactivity, 35% of adults do not engage in recommended level of physical activity for health benefits. And this is recent. At that time, 1988, when we did this, it's 50%. Okay, it's improved a little bit. 25.4% report no leisure time activity at all. They don't even go to a park to walk or to play or to do anything, sports, or go to a gym or whatever. So in 2009, 82% approximately high school students did not participate in 60 or more minutes of physical activity. When I was growing up in Brazil, it was obligatory. Every day we need to do PE. And then went to become twice a week and then once a week, and then they did away. Plus, we have the recreio, right? The breaks, that was all physical. So kids were physical. And when we go home, we outside playing. Now the kids are on a computer. So there's a lot to do with physical activity. So this is a little bit the contribution of your environment. Cars, going to school, back and forth school, by car, by bus, public transport, public transit, and walking, biking. Okay? So you can see that by 1969, about close to half of all American kids used to go to school walking. They walk to school, even though in America since 1935, every children has the right to go to a school that's free until age 17. And the school provides every book, every paper, every pen, and food. The family gives nothing and picks your kid in at your door with a yellow bus. But even with all of that, since 1935, about 43% by 69 of the children will walk to school because it was fun. It was not too far away. We don't wait for the bus, and it was safe. Okay, it's all the combination. Look what happened, these kids going by car. It went from 18% to about 60%. Taking the bus, it went down. Actually, that's the school bus. Most kids are going by car. Okay, look at public transit, meaning I used to go to my elementary and middle school in Recife by public transport. I will walk about 4-5 blocks and then take a bus, go to school, come back. So you have to walk if you take public transport. And so this is all the contribution of the environmental folks. This is real data. I put some literature on that. Increase in risk of type 2 diabetes, heart, blood, vessel disease, and dementia. Now we're going to get into the issue of, are they linked? So you can see here that there's a clear link between metabolic syndrome and cardiovascular. I already mentioned that before. And the reason for that is high cholesterol, not the good one, the bad one, high blood pressure, plaques can narrow and harden the arteries, but more important, the link between obesity and Alzheimer's disease has become more and more, especially in the people who have abdominal obesity. So it's really an obesity-induced insulin resistance that affect your brain in this way. And these are some of the publications. I don't want to go into much into this. I'm not going to spend much time on this. You know that metabolic syndrome will lead you to type 2 diabetes. And these are the mechanisms. A little bit on that. The papers, this one is a good one because summarize a lot of that, the International Journal of Molecular Science. You can see that you have issue with hypertension, hyperlipidemia, obesity, and diabetes mellitus. So they're all coming associated and increasing amazingly the incidence of Alzheimer's disease, especially when you take one item, which is BMI and insulin resistance. There's a huge, tremendous effect in the diabetes. The hypertension, hyperlipidemia is almost like a secondary factor, but they all contribute to cause whatever it's being explained right now for Alzheimer's. I'm not going to get into that. I have an aging expert here, Dr. Ramos. So can we talk then about a little bit more about MS, metabolic syndrome, and dyslipidemia, which is a precursor of heart disease. I'm going to go quickly on that because it is the main cause of death among diabetic patients and among people who have metabolic syndrome. It's heart disease. Okay? And to start, I'm going to give you a general idea how confusing it is for patients. These are two very popular websites in the US, United States. One is the Cleveland Clinic, top notch in cardiology. The other one is this site called Very Well Health. Cleveland Clinic say your HDL, good cholesterol, we want it to be high, above 60. Your LDL, the bad cholesterol, you want it to be below 100. And your total cholesterol should be below 200. Very simple message. I like that message. It's simple. But it contradicts not only with very well, but with somewhat. So it's confusing for patients. Look what they said about HDL and triglycerides. Cleveland Clinic wants HDL to be what? Above 60, and LDL and triglycerides, which kind of associate with LDL, they all come together. But look at HDL here, it's 40 and 50. Here, they want it to be above 60. So it's just an example to show to you that's confusing for patients, okay? But the point is they are at a high risk for cardiovascular disease, especially ischemic heart disease and a sudden coronary death event. Just want to remind you that among mammals, and we are mammals, the average, this is very high, about over 150, close to 210 in cholesterol. But look at the hunters and gatherer humans that we know they still live like that, like the Inuit in Alaska. Their average cholesterol is close to 150. Okay? So it's very similar to average in America. 200 is high, and above that is really high, but it's not that absurd. BMI and the prevalence of metabolic disease, specifically, I'm looking to dyslipidemia, and that means you have your cholesterol off the record, and then you have hypertension and you have diabetes. So you can see that this relationship, it's affected, it's modified by the levels of obesity. You can see here, right? So let's look at diabetes mellitus. It's 1.7 for people who are lean. Like I'm considered normal or lean, depending how you look, because I'm not too tall, and given my weight, I'll be normal, not really lean. To be lean, I'll be like 62, 63 kilograms. I'm not, but I'll be normal. So the prevalence, which is the probability of selecting somebody who is normal to have diabetes, 4.2. When you are obese at the highest level, very high level, over 40, that's a BMI that's pretty high. Your chance nearly go from 1.7 to 27.3. This is 13 times more. Okay, so that's the more dramatic change is diabetes. But let's look at hypertension. If you are lean or normal, you're around 17, 22. Let's say 20. Okay, that's your prevalence of hypertension if you are lean or normal for your body mass index, for your obesity level. But if you have a high, your average here is going to be much higher, right? It's going to be 51 point something. It's about 2.5. So increase your probability of finding out at random a person on the streets with a high hypertensive level of your blood at 51%, when it used to be around 20%. That's 2.5 more. So the same thing happened to dyslipidemia. It was about 24% for the people who have lean. You still can have a very lean person with a lot of bad cholesterol. But as you go up, it goes to 62. That's a change of 24 to 62. That's again a 2.5. So almost like the cardiovascular increase is about 2.5 times. Whereas the diabetes increase is like tremendous, 20 times, 12 times, sorry. You see that? So that's an important message that you be on the lookout for patients like that. Another way to present it is in this table. You can look at yourself. I'm going to skip. So we're talking about abdominal circumference under death. I want to call attention to these papers. if you're interested in learning more about, read those 3 papers. 5, 6 papers. The one that I'm involved with is the one of Kahn. That was Henry Kahn. It's a colleague of mine from CDC, from Emory University. We published those papers back then. And we established for the first time the association between sudden coronary death and abdominal obesity. Okay, and after that, many places start adopting a caliper to measure your abdominal obesity. And in our program now at University of Missouri in Columbia, it's natural. The nurse will measure abdominal or ask the patients to do the measurement themselves. Very simple. Mark with a pen and ask them to put yeah, let's just do that, the circumference. Yeah, it's a caliper. Diameter is another way to measure. It's just the height, okay, to the circumference, to the height at the hips. So it's another way to measure, but it's the same thing. And now we only use, the metric line to do it. Here, a little bit of that. Not going to get to that. It has something to do with number of cells and the size of the fat cells. And just to call attention, this person at the bottom has a kind of a diffuse overweightness and obesity. Everywhere else, this person is big. Arms, legs, buttocks, back, abdomen a little bit, but not too protuberant relative to the body. The other one is protuberant. And the person is heavy, but not as heavy as the one at the bottom. And when that person lose weight, they lose weight, but their belly stays because the fat is in your mental. It's not easy to go. It's not subcutaneous fat. Whereas this guy is your subcutaneous fat. Once he lost the weight, he lost all the risk. You with me? Following that, okay? So contributes in consequence of pathogenic adipose tissue. The term pathogenic adipose tissue is called adiposopathy. It's questionable. Many people say that's not possible. We don't classify, you don't have an ICD for it. Okay? And that's why I wrote, did I write a note here? Maybe somewhere else I write a note. So be careful. Many scientific circles do not accept that. But here, again, remember that first thing I mentioned to you, you're going to see the adiposity and adiposopathy, meaning the disease that come out of the excessive adipose, like the cytokine is elevated, your FFA is elevated, all of those things is going to cause a chain of events on HDL, LDL, atherosclerotic plaque, your liver, your pancreas, your muscle cells will be affected. Remember the negative feedback to the FFA over there? A little bit more on that, you can see here that as your adiposity becomes really what we call adiposopathy is when it's almost like you have a threshold of number and size of fat cells. After that, you stop producing increased FFA and also cytokine, which I did not show in this graph, but you saw in the graph before. Okay, so affect because your fat liver. Once this is very high FFA, you will have fat liver. That's what my brother does. Okay, and then look at the chain of events here, and you have this baby here called cholesterol ester transfer protein, acting as a conduit for all these breakdowns for HDL, LDL, lipase, triglyceride goes up, VLLDL, very low density lipoprotein. Okay, small dense LDL, which is different than LDL, but they are kind of related. And the renal clearance becomes an issue here too. Okay. So I'm going to skip that. This is another definition because you can see that the definition of metabolic syndrome includes 3 major risk factors for cardiovascular disease. And that's why I wanted to show this to you. All your cholesterols or anything related, your fractions of fracture will be affected by adiposity. So the cardiovascular risk factors for coronary heart disease are here. And the metabolic disease is dyslipidemia, hypertension, type 2 diabetes, but these are intrinsically linked with metabolic syndrome. You cannot separate them. Okay, there are the issues I mentioned here. So let's go about the clinical manifestations. If you have patients with hypertension, hyperglycemia, hypertriglyceridemia, reduce high density, like HDL is low, abdominal obesity, chest pain or shortness of breath, acanthosis nigricans, very common in patients who have metabolic syndrome. Are you familiar with that? Around your face starts seeing dark point that really become very exuberant and kind of a little bit, you can feel it. It's not just a color, but become in peripheral neuropathy. Even before you develop a full-blown diabetes, you still control your sugar more or less and so on. And retinopathy start at that point. I have a grant right now to study that. Okay, so you start having retinopathy even before you have years of diabetes, which is the normal range. So metabolic syndrome may lead you to a retinopathy even before you develop diabetes. Insulin resistance, xanthomas and xanthelasma, that's another one, deposition of fat in your skin. Also here, somehow, this area here has to do with a lot of stuff. The acanthosis nigricans, the xanthelasmas over here, usually, and sometimes in your eyebrows, it becomes like a little, almost like an excess skin, but it's actually fat deposition, and with a little bit of a flap, creates a little flaps in your eyes. So that's the diagnosis of any of those could be associated with metabolic syndrome, and they are after many years of metabolic syndrome, even if you do not develop full-blown diabetes. And if you have diabetes, you have those things too. So diagnosis, we know now how to diagnose these 5 factors that you clearly have metabolic syndrome. You're high risk for a lot of things. A little bit on diagnosis workup. How is the time, Luis? It's already 1 hour? I think it is. It is about 1 hour now. So I want you to read this. It's yours. This lecture belongs to the internet and to all of you here at UniFest. The treatment, really, the real treatment of that is lifestyle change. And I don't want to say that I'm overemphasizing. I think this is the most important branch of medicine for the future. Because you want to live longer, and people are living longer. We're living with a lot of chronic conditions. In lifestyle change, we need to study more. We need to do what Dr. Ramos and I wrote an article on centenarians recently on that. And you can see it a lot. It's a very extensive review, even though it's short, but it's very extensive review. And it's really about lifestyle change. Okay? And pharmacological intervention absolutely has to be everything that you have. If you want to prolong people's life, the new medications for obesity and diabetes, they do affect tremendously the cytokines and the phosphatase. So maybe they are at the heart, at the molecular level and cell level, of preventing the inflammation that comes together with atherosclerotic events inside your heart, for instance, or your lungs, or your brain. Okay? So what's the most famous one that the artist, everybody's taking now? Ozempic, right? Ozempic. Okay, so that's have to be studied. I don't think it has studied enough. I had a patient that came to me vomiting for 2 days nonstop because of Ozempic. So the complications are pretty serious. She could have died. But my colleagues are saying the evidence is showing that it does affect tremendously not only your ability to lose weight, but also affect some of the metabolic syndrome levels, like insulinemia disappear like magically. Okay, like the insulin resistance, your glucose go to normal, your blood pressure goes down. A lot of things goes down with Ozempic. This is a secondary effect. Okay, so hopefully we can study more. Maybe Ozempic could be what it is, but also off-label use for treating metabolic syndrome. Just a point. I've been reading a lot about it, and I will make a better sense of it later on. But it's a dangerous drug because it does have incredible side effects. This patient was dehydrated and about to be in shock. Can you imagine throwing up for 2 days, no stopping, and trying to replenish every 5-10 minutes? That was it. So I would say about treatment, lifestyle change is the biggest treatment, but there are many other options. The bariatric surgery, I think, is overused unnecessarily, but in many patients who have metabolic syndrome, I would say absolute majority has resolved the metabolic syndrome. So it's a solution. It's drastic, expensive, dangerous, lots of complications to it, like Ozempic right now. But it's a possibility. In terms of prevention, you know it. I've been harping about this issue since we started. So, getting 30 minutes of exercise, eating plenty of vegetable fruits, lean protein, whole grains, limiting saturated fat and salt in your diet. To extent, I'm in favor of fat. My next time I change, I don't want to be against American Heart Association. I'm a member, right? But very soon I'll make them a presentation say, eat as much fat as you can. This is BS. It's really carbohydrate that turn into fat in your body, big time, the bad ones. But maintaining a healthy weight is very important, not smoking. And to that point, limiting the saturated fat. Okay, but does eating coconut oil, it's a saturated fat, right? Is it good or bad? So the evidence is it's very much in favor of it. Pearls, you can read about it, but therapies that improve glucose metabolism in hyperglycemic patients, reduce blood pressure. This is really the Ozempic point I'm trying to make here on the third point. So ask me a question. We're about an hour.
You skipped the good sleep.
Yeah, I did have that over there.
You had it on the slide.
I know, but it's too many things to cover. Good sleep has been associated with growth in inflammatory cytokine and stuff like that. It goes down. Also, it's being associated with reduced insulin sensitivity, meaning you better balance when you sleep better. Somehow, we don't know exactly the mechanism, but it's like your body needed that minimal time. The problem is not so much the time. The study on sleep and those things like metabolic stuff associate the quality of the sleep more than anything else. But you have to have a threshold, and the threshold is around 6 hours, it looks like. So people say, oh, you need to sleep 8 hours. Many people sleep 6 hours. They are very healthy. That's the evidence showed, if they have all the phases of sleep naturally. But some people do not reach the level of sleep they need, and they be in bed for 9 hours, not going to do any good. So that's for psychological stress, but it looks like the sleep is related to all these stress mechanisms that increase inflammatory hormones in your body. And therefore, it may affect your chances of developing metabolic syndrome and a whole train of events associated with that. I mentioned that. But I think, in my personal opinion, after all these epidemiologists, so many studies, is the combination of these factors, okay, cause the disease for sure, but which one comes first? What do you think, Dr. Ramos? I have my own opinion. Which one comes first?
Weight gain.
Weight gain. To me, is the critical piece. It's the critical element. It doesn't matter where you look at, is the weight, the body weight. Now, if you could gain weight perfectly distributed over your body, also cutaneous, like one of my older brother, I mean, he's 200 pounds. He's tall like you, 189, but nonetheless, 200 pounds. Not actually 200 pounds, no. In kilogram, he'll be about 150 kilograms.
That goes with sleep apnea.
Yep, sleep apnea, which can relate to lack of sleep. So I think there might be some other precursors, but if you could stop people from gaining weight early in life, and the best way to not gaining weight in life is to have an environment that children are accustomed to do the right thing, to eat well, and to exercise, to be active. I'm sorry, Luis, people at your age and my age, I'm not too worried about it. You live a whole life already, and it's hard to change behavior. I've been trying to do that forever. It doesn't change. But the children and the young have a chance to be a new generation that is more active, eat the right thing. And those who have not developed yet in their 20s or 30s, keep up, man. Don't gain weight. Watch out. If you're gaining weight, pay attention to your lifestyle. You change your lifestyle. You cannot change. You don't go from normal weight to overweightness, not even obese, overweightness, without changing your lifestyle. Something changed. Start reflecting on that. That's why I ask my patient, reflect on that. What changed in the past 4 or 5 years? Oh, 2 years ago, I went to this. Oh, okay. 3 years ago, I started working extra hours. So you know who has an incredible abdominal obesity? People who work overnight. Do they sleep? They do during the day. Too. It's a combination. Yeah, it's a combination. But the fact that they sleep in a different pattern against the circadian cycle, it affects the whole hormone. If you measure their hormone, it's all at work. It's not normal. They have a high cortisol level. So I didn't even mention here. Yeah, melatonin is very low for them. Okay, so all these things are intrinsically related, but clearly it's pointing to lifestyle change. And that's the hardest part in medicine, because we have not been trained as physicians, primary care doctors, or preventive medicine doctors. Even though we study, we're not. How do we deliver that? How do we help these people? Okay, so if you are in primary care here at Unifest, you have an incredible environment. Find a way to stimulate people to go to Ibirapuera. It took me 10 minutes walking from the hotel, but maybe from here, you'll be about 17, 20 minutes. If you live in an apartment here, go to Ibirapuera, perfect place. Tons of people exercising there every day. They're getting the benefit of the exercise. Or just be in a nice place, breathing a better air, and then be able to, at night, to have much lower level of cortisol in your body so you can sleep better. And then, if I would say the maximum I would give it to you is that watch your calories, but not count them. Watch it, just overall, just roughly. If you eat a lot in a party, for the next 4 or 5 meals, eat much less than you usually eat. You're never going to gain 1 gram. You don't gain 1 gram. If you eat at night at 7 o'clock, only eat again after 7 a.m. Very simple rule, right? Very simple. Don't eat 2 plates. Eat a good plate with everything. Take a plate, divide that by quarters. 1/4 of what? Can you remember that? Salad, right? Mostly salad can be divided in 2 quarters, right? The vegetable and the leaves. Leaves, a little bit. That's it. Then a little bit of carb, either rice or beans or whatever, ideally beans. And then your animal food or your vegetarian protein. If you have that meal once a day, and then you have a little soup at night with a pizza bread and cheese and so on and so forth, have a decent breakfast, not eating too much, you're going to be satiated. If you are normal, if you already gain a lot of weight, you have a lot more hunger. Eat more. Add 40 minutes of walking every day. If you do those 5 things, you're going to lose weight. Or you want to keep your weight if you have it. So that's my message in lifestyle. There's more to it, but I'm simplifying in the interest of time. More questions, Luis.
So the person with metabolic syndrome without developing diabetes or simultaneously to another?
The question from Paulo. If the person has the metabolic syndrome, can they live a long time without developing diabetes? I never seen one, Paulo. Theoretically, there are many people who have metabolic syndrome for years. They did not develop diabetes, but the follow-up study, cohort studies that were studied, because not perfect studies, they found out that all of them will develop diabetes eventually. More questions? Come on. About
Just wondering on what you said, because I think it goes for everything. I am studying now colorectal cancer here, and all the patients, first of all, they have the disease earlier than before. So previously, this disease was from 60 ahead, and now you have patients with 50, 40, 30s, including children.
Yeah, this is true, okay. This is an interesting point. I think all these chronic diseases are kind of related, and it's also related to the lifestyle change we have, because we've been following up cancer. This is an interesting cancer. She's talking about colorectal cancer. Now, being very prevalent among young people, especially young women between age of 20 and 40. When it used to be a disease that you found after age 50, only after age 50. My time, when I was finished medical school in 1980, it's 50 and older. Most likely 60 and older, you develop colorectal cancer. Now, a lot of women in their 20s, they are made famous movie star, have developed many. So what's going on? Okay. They all have, yeah. Even the young people are having it. Same thing happened to diabetes, Valkyria. The first study to identify that children and teenagers could have type 2 diabetes was the Bogalusa study, and with data from Louisiana. And with my friend Dave Friedman, who was the guy who did all the stats, all the analysis from CDC. So that was like only 25 years ago. My time in medical school, 1974, 75 to 1980, 81, that time, we never seen type 2 diabetes in children, ever. There was not a single case reported, even one case report. It was type 1 diabetes. Okay, now we have a huge number over the past 30 years of children with type 2 diabetes. Now, children, teenagers, and young adults develop colorectal cancer. And heart disease about 20 years ago, start having sudden coronary death. One of the people who I knew from medical school about 20 years ago had a fatal heart attack at age 30. Okay, so this is all part of the same phenomenon. And because the risk factors are all interrelated, it's about lifestyle, diet, excess carbohydrate, sedentarism. Maybe with colorectal cancer, there's something else. People who are very physically active have better bowel movement. That's plenty of research showing that. So the main risk factor of colorectal cancer over the years, you still don't know exactly how colorectal cancer developed, but the main risk factor, where at least one of the most important risk factors, is physical activity. Yeah, fiber is old, but physical activity has been later on proven to be the real thing. My thesis at Emory University, when I was studying that 30 years ago, was colorectal cancer. I had a cohort from the STEER registry in America, and we studied that, and it proved clearly that there was nothing to do with protein or fat or stuff like that. But we didn't have a good measure of fiber, but there was a little bit indirect way of saying maybe fiber to increase, but we didn't have activity, physical activity in that cohort. Any rate, so this is lifestyle change that's causing all this change, because these are diseases we have good record for 100 years in America, about as much in Brazil, statistically. So we know they are changing over the past 30, 40 years. And what changed more? Lifestyle, especially diet and physical inactivity, or physical activity for that matter. Luis.
This talk makes me remember that, you probably know that they're saying that the gut is our second brain. And we are just studying the role of probiotics and prebiotics to keep a healthy microbiota. And an unhealthy microbiota can lead to many things, including diabetes. Do you know any studies with that to design?
I mentioned it's in the lecture, you saw it. There was microbiota was there. Okay, we know it's associated with metabolic syndrome and diabetes. Again, the same phenomenon. Think about it, Luis. What is do we have probiotics and prebiotics?
Yeah.
Okay. Name 3 key prebiotics. I'll name one. That's very powerful. Asparagus. What is asparagus? It's a vegetable, right? So if you eat a rich food with lots of vegetables, naturally, you have fiber, you have these type of...
There are people looking at the prebiotics as feeding the probiotic.
I know, the prebiotic feeds the probiotic. But if you have a very rich diet, let's say you are a healthy human being, you're born and you're not in Brazil now, you're Brazil of 1950, where 98% of the children had breast feeding. At that point in time, just by going to the mother's canal, you already took a lot of their probiotics. And then from the breast, tons of probiotics. And then you eat a very normal, healthy diet with lots of vegetables. That's what we used to have. Then you have your probiotics and your prebiotics. You don't need to take that thing extra.
Yeah, but considering that those people will damage the microbiota through life.
Absolutely.
Probiotics.
So what we try to do with eating probiotics and eating prebiotics is to substitute something that will come naturally, but you can bring the natural back, Luis. You're going to California very soon. The Adventists there in California, they live until 100 years old. What do they have in their diet? Incredible amount of vegetables and fruits. It's a great diet. But they eat other things sometimes, but most often that's what they eat. They don't smoke, they don't drink, okay? But they eat lots of vegetables, right? Yeah. And they are very active physically. So just these two is sufficient. So they are in the same blue zone as the people in Icaria in Greece, the same blue zone the people in Sardinia, the same blue zone the people in Costa Rica, and the other mini blue zones in the world. And what they have in common, they know how to manage stress, they have a purpose, but they eat well and they active physically, not exercise. They don't exercise. They have a normal life that's very physical. And likely, except for one place, all the other 4 places in the blue zone, you have to go up and down a lot. You want to visit a relative, you want to visit a friend, you go up 1 kilometer going up. It's like running a mile every.
As you said, it's very difficult after a certain age to change life habits.
Yeah.
So sometimes it's easier to take these 2 pills of prebiotics and do better, you know.
Yeah, well, you can. It can be helpful. It's like take your Ozempic, take care of bariatric surgery. These are alternatives. But if we are patient, even at our age, we can change lifestyle. I was able to achieve that in a few patients. They changed their lifestyle and they lost a lot of weight and they kept the weight. Do diet works? All of them work. Do they work for keeping people in a healthy weight? No. Most diets, fat diets, diet of water, diet of this, diet of that, diet, doctor, whatever, Ornish diet, they all work. You lose weight, but I mean, nobody, do you want a diet to suffer? You want to eat well. So if you relearn how to eat well, have pleasure with food, cook your own food, eat lots of fruits and vegetables, a variety of sources. If there's a carcinogen, it doesn't accumulate too much because I'm always changing. Don't have monotonous diets. I have a long list of things. Monotonous diets, I eat the same thing every day. If that thing has cancerogenic properties, you're going to develop cancer. But if you eat from a variety of sources, variety of food, every day is a little different. You vary a little bit, and you have a balance. You know, anybody my height, I'm on 171 centimeter, maybe 170 now because I'm old, 67 kilograms. I need about 1,800 calories if I'm not too active. When I'm doing a lot of exercise, 2,400 calories, 2,500. Okay? If you're a woman and my age, my height, my weight, 1,800, 1,700, 1,500 calories may do. But we're eating average eating here, I'm just watching, it's about 1,000 calories in one meal. 600 to 800 in the breakfast, and about 600 to 1,000 at dinner. So people are eating 3,000 or more calories every day. They gotta gain weight. They don't exercise. So we need to change, or those who are in the right range, keep up the good work. Something is working for you, don't change. But if you change, you're lean, healthy, very active, and all of a sudden you start gaining weight, something is going on. It could be a disease, but it's very rarely is. It's usually lifestyle change. You start walking less, you start getting more stressed, start sleeping less, eating a little bit more, compensating, eating a little bit more. Nobody needs dessert, folk, except for mental health. We need. Go to a party, I eat brigadeiro, not a problem. I'll eat cakes, but I don't go after cake every day. I'll eat whenever it shows up in front of me. I don't drink sugar since I was 17. I never put sugar in my thing. And by the way, stop. Oh, I'm drinking this with you know, the, what do you call it? What do you call it here? The little thing you drop in Portuguese. No, but what's the name? The most sweetener. Well, it's a sweet, but there's a name I forgot. The Brazil. Anyhow, almost everybody say, "Oh, I'm using this." Don't do that. I'm gonna have another presentation on this. It actually trick your brain, and your brain actually produce more of the hormone that give you hunger. You're gonna gain weight if you if you use sweetener. You're gonna gain weight faster than if you're eating sugar. You better eat sugar. Of the two poisons, at least one is sugar cane. Okay, but all those little things, if you adjust to your life and say, actually, what I recommended to my family there in Recife, say, go back to your traditional diet. Go to what we used to eat when you were kids, when our parents, grandparents were alive. They wouldn't eat this industrialized food. They would cook every day, lots of vegetables. The traditional food, they're very healthy. Almost every traditional diet anywhere in the world is very balanced because they made you survive for thousands of years, make you stronger. You survive longer today than you were before. Now is the first time we are the first generation. They are living less than the generation before. Because you reach a peak about a few years back because of the earlier diet. Okay, we are the main adopters, the post-World War II generation, the main adopters of the industrialized bad diet. And the new generation after us, you, Paulo, and the young one is actually even eating worse. So we are shortening our life expectation. Okay? Is that good enough?
And what do you think about the diet drinks? You know, that low sugar but high sodium. No?
Diet drink, low sugar but high in sodium. Diet drink, it's a trick. It's water and sugar. So who needs that? You know, most people, they don't like water anymore. They did a research in America. They can't drink water. I hate water. People just hate water. They don't know how to drink water. When I was growing up, everybody drank water all day long. Rarely, I would say, a drink, Coke. It was a treat, maybe on a party or on a weekend or a special dinner that, you know, a guest would come to our home. They would buy something different, but not, you know, the water is the norm. Now is the rarest thing. And if you drink water, they're going to put sugar taste and all of that. So people are becoming very addicted to it too. Bottom line, folks, is that you don't need sugar. Nobody needs sugar. You need sugar for mental health only. So do it once in a weekend. Okay? And don't abuse. Thanks, everybody. You've been a wonderful audience because you didn't ask me a question except the folks who are physically here. By the way, there's something came off on the presentation. I'd like to acknowledge my research grant on diabetes by the National Institute of Health. The number is missing from here. I'll send it to you. So when you share the lecture, the number is there. It's very important. Okay? Thank you. Bye.